So good afternoon. This is a session on, well, it's entitled Health Policy Solutions for California Farm Workers. It's going to talk a lot about health coverage for farm workers, which has been my core issue working on for, 40 years. We're close, but we're not that close. So we have several speakers today. I'm going to try and give some data background, much of it from the recently released UC Merced Farm Worker Health Study that a number of you were at the release on Friday. Just to give you some context, some quantitative context about farm workers and health coverage. And then we have several panelists today. The next is, I think, Juan Do Reynoso, who's the Chief Customer Experience Officer at CenCal Health, which is the local plan in San Luis Obispo and Santa Barbara County. I hesitate only because I've known her in several other iterations, but it is my local health plan, so I actually can find out what's going on with CenCal. Then Graciela Soto Perez, who's a clinic director at the Alturic Centers for Health in Tulare, but also in Woodlake, the school health center in Woodlake.
No,
okay.
We're in Tulare, but I live in Woodlake.
Okay, lives in Woodlake. We were talking Woodlake. And then last but not least, and thanks, is Luz Gallegos, who's the executive director at TODEC, a farm worker legal advocacy organization in the Coachella Valley. So I'm glad everyone could be here. We're going to talk quickly, but hopefully not too quickly, mostly so we can leave time for a conversation at the end. I guess, look at that. I even had slides for all this. Okay. So the data I'm going to show you are from, the room's a little weird because we're here, the slides are there, some people are over there, and we're on Zoom too, so maybe it'll all come together there. So the data I'm going to show you are from several sources. One is the recently released UC Merced Farm Worker Health Survey. And Noe Padamo at the Sierra Leone Foundation and I went to the legislature 4 years ago, got a legislative appropriation for doing the survey, and it was very exciting. And it ended up at UC Merced, but that's a whole other subject we can talk about. If you're going for budget allocations, you want to have more control over the budget language writing. But it worked out perfectly, and we had a release on Friday with 4 legislators, 6 department heads, and Dolores Huerta came and led everyone in pretty much a si se puede chant. So we're moving along on this. The health survey surveyed during COVID over 1,200 farm workers, and also did about 800 medical exams on everything ranging from housing conditions to health coverage, access, utilization, labor, sanitation, and field conditions. The other data are from the National Agricultural Worker Survey, which is a U.S. Department of Labor survey that's done, it's done on a rolling basis, and it's been done for the past 20, 25 years, and they actually go out into the field and interview farm workers on a similar range of conditions. And this is all part of a project that's funded by the Robert Wood Johnson Foundation on expanding health access and coverage for farm workers. And part of the partners in that are UC Merced, the Insure the Uninsured project. Katie was very engaged until she then went over to the Healthcare Foundation, which wasn't bad for us either. And also the California Rural Legal Assistance Foundation. So, is it too small? I guess it is what it is. Just to give you some basic demographics on farm workers, mostly men, 70%. Aging workforce, average age is 39, or average age is 40, the median is 39. So it's an aging workforce. 2/3 are married and have families. Spanish is the primary language for almost all. Nearly all are immigrants from Mexico. 89% speak Spanish as their primary language. There's a growing and somewhat uncounted proportion of indigenous speakers, whether it's Zapoteco, or Triqui, or Mixteco, or several Purépecha. Not a very high educational level, mostly average 8th grade education, so this is important on health information and health access issues. About half are undocumented. So this is survey data, and it's sort of hard to ask. We were not allowed to ask it actually in the UC Merced survey. The State Department of Public Health said we could not ask, but they do in the National Ag Worker Survey. So at least half are undocumented and don't have work authorization. Fairly low income population. So a quarter of families are below the federal poverty level, which is pretty low, especially for working families. On the other hand, I'm going to talk about with the Medi-Cal expansion to cover all undocumented issues, about 40% of farm workers are going to be over income, over the Medi-Cal income. So even though we think we've accomplished everything, we're not quite there. About half do not have health coverage. And you compare this to Secretary Galley today was showing, we started out, 15 years ago with close to 20% not having health coverage in the state. Now we're down to less than 7%. Well, here we're up at 50%. 48% don't have any health coverage. Why? Most of the reason has to do with immigration status, and that's currently not eligible for Medi-Cal, except in certain age categories, but also too expensive. So even when you have employer-offered insurance with very high deductibles, it's just not affordable. And it makes no sense to have a $6,000 deductible when your average wage, your average annual income is under $20,000. Of those with insurance, so that's the half. So in the half that have insurance, about 40 to 50% have some sort of Medi-Cal. Now these numbers don't differentiate between full scope Medi-Cal and restricted scope because it's hard to get down and have that level of questioning. About 20 to 30% have some employer insurance. This is of the half with insurance. So divide these in half and you'll find 10 to 15% have employer supplied insurance. Most farm worker kids do have insurance. In the NAWS, it's well over 90%. In the UC Merced survey was more than 60+% said their kids had insurance. And of course, there's a differentiation between who has work authorization, whether you have insurance or any other coverage or access to care. It's documented versus undocumented. There's quite a bit of difference. So as I've said, if half the farm workers are undocumented, up until recently, virtually none of them were eligible for full scope Medi-Cal. Then, we've added 26, we now have 50 plus. Starting in a year, we'll add the 26 to 49-year-olds and have full eligibility if you're otherwise income eligible. And we're calculating that about 40% of farm workers, of currently uninsured farm workers, are going to be over income. California, the flip side of raising minimum wage is that it kicks you over the 138% of the poverty level pretty quickly. So just quickly on some utilization. I realize I'm probably taking up everyone else's time. 22% had no usual source of care. 65%, so 2/3 said they had used a health provider in the last 2 years. But it's much more likely if you're insured to have used a health provider, and you're also much more likely to have gone to a private clinic. I'm going to skip a lot of the fine print here and just sort of give you some of the, we talked about policy solutions. So what are they at this point? One is, can we raise the Medi-Cal eligibility limits beyond the 138% of the poverty level to say 250%, and what would that accomplish for farm workers? And some raw numbers would show about probably 80% coverage if we can kick up the Medi-Cal eligibility limit. And then it would really have the benefit of being full family coverage, because most of the kids are already on Medi-Cal, and their income, the eligibility limits is up to 250 or 266% of the poverty level. The other way to go is to keep sort of the current system and make Covered California available. There are two ways to go on that. One is through what Washington State and Colorado have recently been able to do, and that's to get federal approval to open up their health insurance exchanges to undocumented workers. The other way, as Anthony and I were discussing last night, is to have a mirror exchange. I was calling it a shadow exchange, where it's just basically keep Covered California, but create a state Covered California where you don't actually have federal involvement, and we can do that. Now that would be all great and good, except the cost of insurance is still incredibly high. So the biggest issue is going to be subsidies, and how do you provide some, without subsidies, you're in the same place you are now, which is you can buy the same insurance on the private market. So that's going to be the biggest thing. The other policy things that we've looked at, and I did a series of 20 interviews, several of which with people in this room in the last couple of months, is Medi-Cal, we know, is a managed care program, but it's very local and regionally based. Now, 20% of farm workers actually migrate for work. So it doesn't really help to have a county-based program in Tulare if you're actually, working in San Joaquin County. So are there ways to have some sort of statewide program, either through the fee-for-service program or have some sort of special statewide eligibility program? As part of that, we do that for foster youth. We allow them to enroll in fee-for-service as opposed to being at a regional managed care program. And then I'm going to skip over the employer-based insurance, just in the interest of time, and plus interest is not really high, I have to say. But then there's a lot about CalAIM, and CalAIM is not going to do a whole lot for farm workers. They're a high-need population, but they're not a high-cost population. And remember, the CalAIM groups are really focused at people with severe mental illness, unhoused folks, and folks transitioning from incarceration who've been high utilizers, high cost. Farm workers, for many reasons, actually don't use the system a lot and don't cost a lot, but they have all the same needs, for all those wraparound services, for all the other services. So it would be nice to figure out how to shift farm workers and farm worker families into CalAIM. So I think what we're going to talk about, and I'm going to skip this slide because we can come back to this, but you're going to hear it from all the other presenters, is what are some of the barriers, but also what are they doing to sort of overcome these barriers? Because making coverage available does not equate to actual enrollment. Enrollment does not equate to actual utilization, and utilization doesn't actually necessarily equate to improved health. So we'll hear from our three panelists about how to sort of improve, the ultimate goal being improving health of the farm worker population. And I'm way over my time, but I appreciate it. But being in charge. Okay, we can go. Oh, you see, we already have more time. Okay. 5 minutes more. Okay. So here.
Could I have that?
Yeah, you can have that, and I'll tilt it so it's logistically it's a little hard
Yeah.
to, because
I can
we
see
can't
through
see
that.
the slides.
I'm good.
There you are. Okay.
Good afternoon. I'm Vondo Reynoso, and as Joel said, he knows me from several reiterations. I started out my career as a public health director in Madera County, and that's where I first met Joel. And then I moved to Santa Barbara County, where I was also the public health director. And I am now with CenCal Health, and happy to represent CenCal Health on this panel. So, who we are a local Medi-Cal managed care plan. We are one of the 6 MCPs in California that operate under the COES model, and COES stands for County Organized Health System. And the neat thing about COES is that most of them were formed out of advocacy by the healthcare system in their communities. So as such, because they were formed, birthed, created out of the local communities, there's deep-seated value to honor and subscribe to community partnerships in how we operate. We have been in Santa Barbara County since 1983, so that means that this year we get to celebrate our 40th anniversary. We are also in San Luis Obispo County, and that's been since 2008. And we are headquartered in Santa Barbara with offices in San Luis Obispo and Goleta. So our membership, we have just a little bit over the 229,000 Medi-Cal members, and for every 4 residents in Santa Barbara County, we cover 1, so 25%, and 1 in 5 for San Luis Obispo County. The question that Joel asked of me is how as a Medi-Cal health plan, how does CenCal invest and support the farm worker community? And we do that by funding outreach and engagement efforts. Joel mentioned recently the UC Merced Farm Worker Health Survey, and when we realized that there was an opportunity for us to piggyback on that by commissioning the UC Merced to expand their sample size to the Oaxacan community in Santa Maria. We did so, and out of that we now have more detailed data about the Oaxacan farm working community in our county. So therefore we can tailor outreach services to that specific community. We partner with trusted community leaders, and it's as I mentioned earlier, it's a deep-seated value that while we are a health plan, we depend on our boots on the ground, trusted community leaders to make sure that everyone who is eligible to be covered gets covered, and not only get covered, but get access to the services that they need. We also partner with our provider community. Here is a picture of one of our providers. We elevate our providers. We value them. We count on them to be our extension to serving the community with clinical services. And here is a picture of our CEO presenting the ACAP award to the medical director, Dr. Clark, for being a excellent safety net population provider. Our outreach efforts, we continually partner with FQHCs and county public health to do outreach. And this is in reference to, we always think about, as a health plan, how do we ensure that the eligible populations, and in the past when that eligibility has been expanded to cover more kids, more young adults, and older adults, we don't rest on just that regulation, that availability. We rigorously pursue partnership with FQHCs and public health to do that outreach. And we also support our CBOs and trusted messengers to do so. And more so during COVID than ever, we realized that during COVID, our trusted partners needed extra help with printing bilingual materials, needing incentive dollars, needing social media expertise. So we gladly partnered with all of our providers and CBOs and community partners to do so. So the question is, with the increase to preparing for the next big expansion to the age group 26 to 49 years, what have we learned that we can put in place? And when I assembled my team and I asked them this question, and it was really good that they realized that we learned a lot through the COVID pandemic with regards to how do we reach to our community in an effective manner. So it's not necessarily going through the traditional radio, print, television. It's also expanding our outreach efforts in common visited places in the community, like laundromats, like meat markets, like grocery stores, like the park. So we will continue to do that. The other partnership that we are excited about, not only to prepare for the next expansion, but for the redetermination as well. And that's partnering up with our County Department of Social Services, who enroll community members. And it's being there and making sure that we have culturally and linguistically outreach materials and able to support events. So with regards to the question, whose role is it to ensure that new members are accessing services? When we get our list of new members assigned to our health plan from the state, we send out packets, and the new members receive an automated call with highlighting key information, and it's specific language. And then we follow up with a patient navigator making calls until we've made that connection. When we assign those new members to providers, we also follow up with the providers we're creating this fancy dashboard to measure how quickly do the providers reach out. There's 120 days requirement, but we want to do better than 120 days. So we're measuring that, and we're incentivizing our providers to do so. So what have we learned with the previous expansion efforts? We've learned that we need to be proactive with community partners and providers. We can't rest on, oh, that's their responsibility. As a health plan, we want to be proactive and engage and supportive. We want to make sure that we do more real-time Spanish radio outreach, and that means hiring staff. A lot of our opportunities, it's not bilingual, so we have to make sure that we hire and engage staff who are bilingual and won't need interpreters. We have to be innovative in our partnerships and community forums, and that means that partnering up with community advocates, partnering up with emerging community organizations, investing in their infrastructure. And we've made a commitment to disseminate bilingual communication simultaneously. Oftentimes, we'll see that entities will release English press releases, and we through the pandemic, we made a decision to continue forward with disseminating information in a bilingual capacity. So I want to end with sharing with you our vision. Our vision is to be a trusted leader in advancing health equity so that our communities thrive and achieve optimal health together. And what that means to us is that we will need to continue what we've been doing, which is being very committed to building partnerships with the healthcare system, with community advocates, and with CBOs so that together we can move that needle in our community. Thank you.
Great, thanks.
Good afternoon, everybody. Do we have any providers in the room? Anybody seeing patients?
They're all seeing patients.
All right, well, I'm going to be talking on behalf of a clinical perspective, what we're doing. So my name's Graciela. I'm the CEO for Altura Centers for Health in Tulare. Anybody know where Tulare is? Oh, okay. A lot of people say, I don't know where that's at, but that's south of Fresno. So that's where we're at. And so Altura is deemed a federally qualified health center, which everybody throws out. It's FQHC. That's what we are. We are a nonprofit. As you know, FQHCs can also be public entities such as district hospitals, which we have a few still left, and counties. But we are a full FQHC. So in last year, we had about over 27,000 unduplicated patients, and we saw over 150,615 billable visits. I say billable visits because as an FQHC, we cannot bill for such things as nurses visits, or transportation visits, things that cost us, but we can't bill for it. FQHCs are required, we've always been required to treat patients regardless of ability to pay. Now, it doesn't mean we can't send you to collections, but if we do have those payment plans, the sliding scale fee that is required by the feds. And also that's why the feds give us a Section 330 dollars to help the uninsured population. But as hospitals with the EMTALA law, we do not turn anyone away. We do not ask, do you have a social security or so forth? We will treat you. We're here to take care of the person, the individual. We don't take care of the ICE or INS issues. So servicing the farm workers. So those of you who are familiar with the Central Valley, we are very high in the citrus. We're one of the largest bread baskets in the country. We actually have the International Ag Fair going on this week, coming week in Tulare. And so here we have some of the services that we provide to the farm workers. So we do a lot of educations. We partner with the radio station La Ley. And we go out, this is the cuadrillas, we call it the cuadrillas. The cuadrillas are our farm worker crews, and we take our team. Some are MAs, medical assistants, some of them are CHWs, and some of them are promotoras. We have both. And we do glucose, hemoglobin, blood pressure, height, weight. We do education into covered California. Sometimes the staff will take the laptop and we'll connect via hotspots. Some areas are very difficult due to connectivity, like what they were talking about. Some of these areas don't get that. We also educate on test results, education on health topics. We sponsor the free lunch. That's how we motivate them to come and see us. And we do raffles, and we do COVID-19 tests. And sometimes we'll do the COVID vaccinations and flu vaccines. They've been more receptive with the flu vaccines. The COVID hasn't been as very popular. It's been a challenge for us in the Central Valley. Right, Mary? She's over here from, we're part of Central Valley Health Network, our consortia. And so you can see there the pictures of the images of our team doing the testing. So we even take the weight. We actually get it calibrated and make sure. And this is how we farm our oranges. Because I've noticed there's pictures where people have boxes. I think that's how they harvest in Florida. But we carry the sacks. That's how we do it. And in these big bins, we don't have those wood boxes. These are the bins, and this is how they get paid. Right now, depending on the size of the orange is how they get paid, the farm workers. So that the bin could be such as $30. I remember when they were like $11 when I was a kid. And it takes hours sometimes to fill it, depending on how good of a picker you are. That's for citrus. The next one, so another thing we do, because we also have grapes in the area. Selma is known for, as you all know, the raisins. That's where most of our raisins come from. And when I was a kid, I used to pick the grapes for raisins. It's a lot of work. So what our team does, this is our outreach team, our CHWs, they will go out there, and the farm workers get paid on productivity. So what they do is the employee will go out, and you can see one of the employees, they have the Altura logo on the sleeve. She's picking for the farm worker while we're educating them so that they don't lose productivity. They continue to get paid. So that's something else we do. So our core services, of course, these are the services that we provide not only for our farm workers, but for our whole population. We see anybody that comes into our doors, but our basic core is family medicine, internal medicine, OBGYN, pediatrics, and dentistry. We also have a lot of specialty. We are very fortunate to have behavioral health, hematology, nephrology, neurology, oncology, ophthalmology, pediatric cardiology, adult cardiology, podiatry, general surgeon, vascular surgeon, endocrinology, ENT, and chiropractor. And all of these services we have in-house. The ophthalmology one, we're also doing televisits through the retinal, the iris machine. We also do a lot of education, and there we go. Some more services that we provide are here. We do the Zumba is very popular, but yeah, the farm worker crews, vaccinations, yep. A lot of other services. I know we're short on time, so I'm just gonna go. We do one of our OBGYNs, our OBGYN director, we used to do the LEAP procedures in the hospital, but that's thousands of dollars. I don't know if you guys know what LEAP is. It's a woman thing, but in order to prevent and prevent cancer, we started doing the LEAP procedures in the clinic because we can bill the PPS rate. Unfortunately, we have one of the lowest PPS rates, but it could be as much as $150 versus thousands of dollars in the hospital. So that's why we started doing some LEAP procedures in the clinic, because of this issue where the undocumented did not have access to those services. And that way we protect and save a life. That's our goal. We do a lot of student internships and so forth. Prescription assistance through the 340B program. Some of you may be familiar with the 340B. We contract with Walgreens, CVS, Rite Aid, Walmart, so that our patients who cannot afford their medication can access it that way. We accept most payers. As you can see here, we are a two-plan model. Anthem and HealthNet are our health plans, and our IPA is currently now Dignity. Some of the challenges we have for the uninsured is anything that we provide in our four walls is covered, but anything outside is our challenge for inpatient care, surgeries, anything need lab or imaging. And what visit do you guys go that don't need labs or imaging? And those are items that they can't afford. But the provider needs it to do an accurate assessment of the person. Addiction to treatment, inpatient services, hospital stays, surgery. So this is a great for those 50 plus that are not going to have access to that. We also have enrollment counselors. We can enroll patients into Medi-Cal. So that's another thing we're doing, and we're going out there when we do the outreach. Anytime we take that. We also go to the swap meets, because that's a good place where you can find a lot of people. I don't know if I'm going to be able to pay this TikTok. I don't think so. I wanted to show you guys what we did with the. Can it play? That's what we do every Christmas. We call it a posada in the small little community of Woodville. Oh, I guess it does. Can you do play? Is there a play?
He would have to do it.
It could just we can see what they're doing. Oh, there it is. hot chocolate, cookies. We have fruit from the food bank that we pick up to give away. We do free vaccinations for COVID, for flu. This is in December. That's our team. And so you can see here, we're giving the injections. There's our community-based organizations join us to give information. And you can see people going. We have raffles, the hot chocolate, the pan dulce, which is a sweet bread. We have games for the kids. This is a very small community, doesn't have anything. So we bring in Santa Claus for the kids there in that community. You can see there the Tulare County Migrant Program also join us. Lead protection, very useful information for the community. And so we also, all of our employees donated toys so that every single child could have a toy. You can see how, and our board participates. We give them a little Christmas tree.
Welcome, have fun.
And we do the Zumba, that's the Zumba. And you see the kids are just having fun. And that's our CMO, and they're breaking out the piñata. And you can hear the kids chanting.
Yay.
So that's community, and so my time is up, but that's what we do. How we do.
Should just be the next one.
The next one.
Yeah. Oh, keep going.
One more. There we go.
Okay. Hi, everyone. Luz Gallegos. I'm with TODEC. TODEC is an acronym for Training, Occupational Development, Educating Communities. Very blessed to be part of this organization. I actually started I was very young when I started. I was part of TODEC's youth leadership pipeline. So in the picture, you'll see some of our monarcas luchadoras, which are monarch butterflies in the struggle. That's a translation from Spanish to English. But TODEC was founded in the Inland Empire. We're from Riverside, San Bernardino County, out of the need to organize around farm workers. During the 80s, when TODEC was founded by our founders, they were organizers during the farm worker movement. But when they moved out to the city of Paris, has anybody heard of Paris? Okay, good. Because when I'm in sessions and I travel and I'm from Paris, they're like, oh, there's organizers in Paris. I'm like, oh, Paris, California, not Paris, France. So Paris is, we are a border region. Paris all the way to the Tijuana border, and Coachella all the way to Mexicali, we're a border region. So during that time, and currently, Border Patrol has jurisdiction over our streets. So back in the day when the growers didn't want to pay our parents, our farm workers, they would just call Border Patrol. They were already in our streets, and they would come and deport them. Thank God back in the day it was easier to come back in. You all heard that saying, aquí estamos, y no nos vamos, y si nos echan, nos regresamos. Well, that came from back then. We are here, we won't leave, and if you deport us, we'll come back. Of course, that's not the same story now. It's definitely has changed, but out of these realities of our farm worker community, that's how our founders founded TODEC to organize, being one of the first immigrant justice organization in the Inland Empire that we've always been underfunded, overshadowed by many counties. We are very resilient. And the struggle is very real in these communities because Border Patrol has jurisdiction over our streets, and if they have probable cause, they will deport us. So these are the realities that our farm worker community lives in, and with TODEC, the youth leadership pipeline, which we have here, is we're a base building organization, so we have members. TODEC has thousands of members throughout the region, and it's very generational. So my parents were members, my grandparents were members, my kids are members. So we have very deep roots in the community, and that's Monarcas Luchadoras. We always highlight our youth because we all come back to community in different capacities. I volunteered for the organization for 30 years. I've been working for the organization the last 10 years, but it's been very rewarding. So through the work that we've done through advocacy, our first win was the IRCA, which was the amnesty. Our founders were part of the think tank to get the amnesty passed, which better known as La Amnistía. Have you guys all heard amnesty? La Amnistía, which helped particularly farm workers get their immigration, their green card, and so forth. But being an advocacy organization, we also work on implementation. And that's why this panel, for me, it's very personal, because we're talking about implementation of Medi-Cal expansion. We organize, we mobilize, and we advocate to elevate the realities of community. My presentation is very visual. We're very visual at TODEC. These are some, through the work with the organization, we became a service provider because of the work of the amnesty. We passed this law thanks to a lot of partners across the nation. And now we had to come back to the communities and implement to help millions of immigrants, particularly farm workers, to get their immigration status going, their legal paperwork. Back in the day, we didn't have many attorneys in the IE. People have to drive to LA, very expensive. Our farm workers didn't have good transportation. So that's how we became a legal service provider, to fill in the gaps of the Inland Empire. So through a lot of work, though that we're an accredited department, accredited by Department of Justice, but we have staff attorneys that work with the organization. But our motor is organizing, base building, and advocacy and civic engagement. But I'm showing this here, these pictures, because the history of Health Raw is not new. It's been, it's many, many decades. We've always, with what our priorities as an organization comes from our member base. So whatever our base is telling us, that's what we need to push, that's what we need to push. And I'm happy to see great partners like Health Access and I think CIPC, I'm not sure if they're here, but because it's a collective effort through the years, 40 years, our farm workers not having access to health care, that's been always the struggle. I mean, not having, of course, the employers were, many do not provide it. So through that lens, organizing to get things done. And we all started when our first win with, as far as the healthcare expansion, was the kids. And you'll see some of the pictures here with the kids. But with the kids situation, it was very easy because a lot of the kids, as you know, they need to get their vaccinations, placed and all that. So it was very simple for the expansion. So through the advocacy, we worked on implementation. Since then, we've launched a campaign, a partnership, a very tight partnership with our counties, both counties, Riverside, San Bernardino, and also our two major service health plans, which are IHP and Molina. So we've had this partnership since Health for All Kids, when we launched, to make sure that every person, every child that to make sure that the information was out there and that the information to our families were out there and that they knew that it was safe for them to enroll, that it was not going to trigger any type of situation, especially when we're talking about public charge or any situation that will impede them from having a green card in the future. So now with the Health for All, even with the expansion with the expansion with the young adults. But now what we have been working on is implementation for 50 plus, and we are very worried because even just how the compañero here shared the thresholds is real, and we're seeing a lot of our folks are not able to even qualify for the Medi-Cal expansion. So we are very worried about the expansions, and now seeing the threshold come up in 2024 from 27 to 49 for undocumented immigrants. That's our working class. That's our working class that still don't have access to Medi-Cal expansion. And through the work that we've been doing on the ground, we are very worried that, that this population is not going to have access, an access that they deserve. We've lost so many lives due to COVID, and we keep on losing lives. We've lost lives before COVID. And as an organization, we continue to elevate and push. But just how we told the governor, through COVID, there has to be systems that address the immediate needs in the lifestyles of our community. Working community does not go knocking on doors of government to access benefits. We have to be on the ground. We have to be on the ground, going to the fields. These are some of the pictures of our outreach. We are going to the fields, enrolling. We're taking DPSS along with us within our outreach and education that we do throughout the year, which is know your rights and everything that we do with our workers. They're actually coming along with us and enrolling on site. So this has been very successful, working with the region, and for them listening to TODEC and pivoting with us. This has been very successful in our region, that we actually have their ear, because they know we, as an organization, our best interest is a community agenda. Knocking on doors, but of course, elevating the needs of reality, the reality that for us, as an organization that was part of this advocacy effort for the expansion, it is our moral responsibility that every corner, every immigrant in our region knows about Medi-Cal expansion. But also at the state level, working with partners across the state, being on the same page, that we have to make sure. It took a lot of advocacy, a lot of lives of our community members, that we want to make sure that we partner up with everybody that we need to partner up with, that we're getting the word out, but that it is accessible and it's on the ground. We're doing a lot of door-to-door. We do door-to-door all year round with TODEC. So we have also public DPSS coming along with us. Right away when the governor signed the bill, the next day we had a town hall. Over 500 workers came out, and county was already enrolling them. I don't know how they do it, but they were already enrolling them. So I don't know if it's something with our county, but I mean, in every town hall we have, which is once a week, people are turning out. Hundreds of people are turning out. Our community centers, we have offices throughout the region, Coachella, Paris, and San Bernardino County. People are turning out because they trust organizations. So I just love las compañeras here, because the same work, we have to continue replicating this work across the state, because it's just so personal. And I just want to share, I just want to share this, because I think everybody, if you're here in this space, it's because you care about farm workers. And I think this has been our moral compass for our organization, to push harder for this population of workers, that they give their life to our state and have never received anything in return. Earlier, I was in a conference. Iriri went to visit us in Coachella, but I'm here, and we're saying we need not only healthcare, but we need all the safety net programs that our workers deserve. Because of stories like this compañero, he's one of our members. He's one of the first farm workers that passed away in our region due to COVID. COVID hit our region in March 2020. And we have a 24/7 hotline that we only activate when there's emergencies that impact farm workers and immigrants in the region. In our region, our immigrants and farm workers know it by heart. It's TODEC 911, like emergency. So right away we activated our hotline, and we started getting calls 2, 3, 4, 5 in the morning. Our folks weren't sleeping. We weren't either. We were collecting data to push policy and to create systems. And one of the calls that came in was Jose's daughter, and she said, I want to talk to Luz. So our operators sent me the information. I called her, and she said, Luz, my dad doesn't want to stop working. I'm like, we know he's sick. He doesn't even want to test. So I called him, and I said, ¿Qué hubo, compañero, que está enfermo? What's up, compañero? Are you sick? I hear you're sick. Your daughter's calling me. And he's all, yes, but I can't stop working, because if I stop working, my family doesn't eat, and they can't pay their rent. This is a very common message that we heard from our farm workers across the region. And this has made it so much more personal than what it already is,
to keep on pushing, that we cannot wait till 2024. We need action now, especially putting forward a program that really addresses the needs and realities of farm worker population that feeds us. We cannot wait to eat. Our workers cannot wait for health care coverage. They cannot wait for unemployment insurance to have access. We need to push harder. And I'm calling all of you all a call of action. We need to do more for our farm workers. We were part of the UC Merced study, and it's collecting data of information we already know as organizers. We've been hearing the same situation for 4 decades. Same stories, but now aggravated to the times 100% because of COVID. We are seeing how long COVID is impacting our communities. We have one of our members has gone blind. They're tying it into long COVID. A 39-year-old farm worker. He doesn't even have access to Medi-Cal yet. This is the reality of our workers that during the harvest season, when they're on harvest, when there's harvesting, they're harvesting our food, but when they're off, when no está la cosecha, they don't have access to unemployment. So it goes hand by hand. Unemployment, safety net programs with healthcare, because we want to make sure we're protecting and defending our most valuable asset of the state of California, which is our farm workers that are providing the food that we eat. Something else I want to elevate, which is very important, not only for my organization, but for so many other partners across the state, that the state needs to invest in nonprofits like ourselves, like los compañeras here as well. Though that we don't receive any funding for education and outreach that we're doing with the county, we are doing this out of our moral responsibility, that we have our volunteers, our youth, that have been trained to do the outreach, because we don't want to expose our elders because of COVID still going on. And these are monarcas luchadoras. You see them in Sacramento, you see them everywhere with their wings, because for us, they're heroes. We're heroes. But we're doing this as a volunteer basis. We don't receive any funding for the work that we've been doing since Health for All Kids. We do it because we advocated, and it's time when we implement, we want to make sure that the laws that we advocated and pushed are being implemented and are reaching every single corner of our region. And I think it's our responsibility to continue pushing that, but it's also the state's responsibility to make sure that the implementation is the most important part, that we want to make sure how laws like this actually reach the grassroots in every single way. So I'm calling, if there's policymakers here or anybody that has power or connections, we need funding, not only for TODEC, but for a lot of grassroots organizations that we're working off volunteers, because it's personal. Because of stories like El Compañero, and I could share, we have thousands of stories I could share with you, but this is so personal that El Compañero passed away, and on a Sunday morning, his little 8-year-old son Carlitos found him dead. This is not over. We need the expansion now. Our working class is the one that's waiting for 2024. The state has to put forward a program that really addresses farm workers where they're at. Farm workers are the biggest asset of our state. That ag is the backbone of our state's economy, and we need to continue doing more. Not only for our farm workers, but undocumented immigrants that don't have access to privilege. Again, unemployment insurance, we're pushing that safety net for all, but also health for all. Single payer is an opportunity that we have, Medicare for all. Thank you so much for the opportunity, and our struggle is not over, but we need all of you guys to be part of of la lucha, the struggle, because this is very personal. We are still losing workers. Long COVID is hitting our farm workers like you don't even know. Some of the mayordomos, they with long COVID, since we work very closely with public health, their mobility has been affected. You can't work for us anymore because you're high risk. Our farm workers are not disposable. We need to treat them with dignity and the respect that they need. Thank you very much.
Thank you all to my panelists. We have a few minutes if there are questions, and I think people need to speak at the mic because we're also doing it by Zoom. So if you have a question, if you want to just go to the mic and ask it, or bring the mic over. But I again want to thank the panelists here and thank the ITUB staff and our tech support, which is, hey, we got a video going.
Ms. Gallegos, you mentioned public charge and having to convince people that public charge would not. How significant is that now? Are you still attempting to convince people that they're not going to be affected by the public charge rule? And then, Mr. Derringer, I had a question for you. What does 138% of income versus 250% of income look like?
Yes, thank you for your question. As far as public charge, it's still a nightmare. It's something that's still lingering within the communities. So what we have been doing in TODEC, since we have a legal side of the organization, we incorporate the public charge legal into all our town halls and all the work that we do with the county on the ground. And we have, our attorneys, when people have questions or they have fears, right away our volunteers or DPSS, refers them over to us. So we have a screening. So as far as the community, but they're provided the most up-to-date information with public charge. Of course, public charge, depending on the situation, but it won't trigger, but it's still a peace of mind for our farm workers and our immigrants that are trying to access this. So it's very important to partner the state of California through the DPS, Department of Social Services, I want to say. We have a lot of organizations are partnering up with that accredited or partnering up to provide this type of support, and it's statewide. So within our region, TODEC is one of them. So if I could provide that information as well as a follow-up.
I'm quickly looking. Usually I have, I have a notebook that I put the eligibility limits in, but I didn't bring my notebook today. I'm like,
Neither did I.
I'm looking close. I'm trying to pull up the report I've been working on. I would bet, let's see, 138% of the poverty level is for a family of one. I think it's about $15,000 or $17,000. Wow. Is that right?
That sounds right.
17,000. See, someone would know. And if you really do the math, you can back out. Well, where are my data people? They're looking at each other. It's like, all right. So what's the answer here? We're going to refer to our data experts here.
Over 18,000 for a single person.
15,000. That was good.
18.
18.
And 250 is almost 34,000.
34,000.
For one person.
That's for one person. I will tell you though, with the new minimum wage in California, if you work 30 weeks a year, you're over the Medi-Cal limit. Wow. That piece I found. So, there's benefits and there's burdens in it. So it's a fairly low limit. Now kids are much higher. Kids are at the 34,000. Well, that's for one. It's much higher for a family. Anyway, but thank you for the question. Other questions?
I just have a quick question.
Sure.
I'm Sam from Aria Community Health Center down in Central Valley. One of the biggest barriers we've been seeing is transportation for the farm workers and their families. In the Medi-Cal rollout, is there anything to put that into it? If you look at our areas, Tulare County in general, over 4,000 square miles. So trying to get that out there.
Yeah, say hi to John. So what we do is we got it through the Section 330 funding with HRSA when they released the grant. So that's how we got, because we're deemed a migrant health center. I don't know if you guys are deemed a migrant health center as well. So we got some funding to purchase a shuttle because we provide free transportation to all of our patients to and from our facilities. And one of them is for farm workers, but we have it look just like the others so that they don't get discriminated. But that unit and the driver is specifically for farm workers. But that's how we got ours, was through HRSA when they released the grants.
I should also add, and
Yeah.
you may say it, transportation is a Medi-Cal
That's
benefit.
what I was going to say.
Right.
So you might want to reach out to your Medi-Cal managed care plan, and it is something that's required for the plan to authorize and coordinate.
Yes, Anthem and HealthNet will provide the transportation to specialty or other places where we don't transport.
So some of that is, as Luz was saying, it's the implementation. We've done well on policy. It's the
Right.
implementation on the ground where we need to do better.
Correct. My question is because I'm like Motive Care and everything else, because I'm also an ECM provider, so we're doing the specialty portion of it. My question is, say, from like Tulare to Early Mart, so if there's only one vehicle, is there going to be like a reimbursement for the expansion? That's what I was trying to get into. Because if you look at our areas for the farm workers, we go out to Tipton, Allenshurst, Alpal. That's 40 miles from one of the closest medical centers, going back and forth, back and forth. A van can only carry 6 people. When you're looking at a reimbursement system or anything in that nature, is Medi-Cal trying to do anything? That's what I was trying to get at. Sorry, I didn't clarify fully what I was trying to get at.
No, it's a big issue on the provider side and a bigger issue on the patient side.
Right.
It's 2:05. I think we've been graciously provided with 5 minutes over. So, they may invite me back as moderator if I keep us on time. No, they're not inviting me back. Oh, well. Okay. Again, I want to thank our panelists and thank all of you.